Hi, good morning. Welcome to this episode of Guts and Glory, wherein I have a renowned gastroenterologist, a compassionate, well rounded, and my professional twin who has his heart in the right place. Let me invite Professor G. Choudhuri, who's the chairman of gastroenterology at the Fortis Memorial Research Institute at Gurgaon. He was formerly the head of SGPGIMS Medical Gastroenterology Department for several years, and that's where we shared a deep bond and which is continuing since then. And I'm really delighted to have you on this podcast, Dr. Chaudhary. It's a pleasure to have you here.
Sadiq, it's a unique pleasure. We are connecting after a long time and this time over Zoom. So it's good. We used to have more direct conversations over a cup of tea,
Yeah.
trying to decide what to do with patients. But now I think technology has taken us in a different way.
I want to get back to that. You remember since long in SGPGI when we started in 90s, early 90s. You remember we had a serious thought that medical and surgical gastroenterology should be a single entity simply because we deal with common problems and we probably have common solutions and a choice of options to be exercised. I don't know, over a period of time, I feel that the unified sphere has become very narrowed now. I remember we used to be participants in Indian Society of Gastroenterology as a equal shareholder, but I don't see that kind of interaction and working together kind of thing. What do you think? Was that a good thing to do? Does it make sense? And does it what do you think about that strategy at this point of time?
So, Sadiq, everything I think is a matter of evolution with time. So, if I might take you a little behind, if you remember, you are quite a few years younger than me. So, earlier on, gastroenterology meant that treating diarrhea with medicines. Okay, so there was really nothing else that one could do with one's hands. And I think obviously everything where a structural fix had to be done, it had to be done by surgeons. So I think those were good days. Surgeons obviously were the pioneers in setting things right. So, surgeons can cut, they can stitch, they can open up narrow things, they can resect, and so on and so forth. But primarily, it had been more on the mechanical fronts. Needless to say, those were the days when it was open surgery most of the way, and therefore it had its own problems, like an open
Right.
cholecystectomy and so on.
Yeah.
There has been a lot of effort over the last, say, 40 years of how to make things a little less invasive to the for the benefit of the patient and for the benefit of the medical care. Uh, to give an example from your own area, you see when laparoscopic cholecystectomy came, and precisely the year was 1989, 90, that
Yes.
time. You see, even before the trials came out showing that it was beneficial, most patients had actually offered to go in for a lap chole, okay, so forth. So the problem that happened is that unlike this example that I gave you of laparoscopic cholecystectomy, that area has still remained with the surgeons, and rightly so. I will tell you another example from the good old days because you are from All India Institute. So, diagnostic laparoscopy was started by the medical gastro department by Dr. D.K. Bhargav.
Yes.
And, we were residents and we used to go and watch him doing diagnostic laparoscopy. He would take a biopsy at best. Ultimately, it didn't quite work out because more or less you realize that only diagnosis doesn't have much of a role. Once you go into the laparoscopic space, you have to also do some therapy. And therefore, most people who took it up thereafter have been surgeons.
Right.
On the medical side, what happened is we got endoscopy, we started not just looking but also doing. So, for example, treatment of portal hypertension, dilatation of strictures, and so on and so forth. which I think evolved. And to be fair, most of the endoscopists of the 70s and 80s were actually surgeons.
Yes,
So,
yes.
they were more familiar with anatomy. They were actually a little more bold. If something happened, they would be able to intervene better. And then there came a plethora of evolution of techniques and studies and, so on and so forth skills. So then it became a little apparent that a surgeon who was very good and skilled in doing more complicated things, should he be wasting his time doing diagnostic endoscopy or doing a sclerotherapy, which is actually doesn't require that much amount of skill, and the surgeon skills can be probably better put to use in other places.
So, why I was asking GC this thing is that, one is concerned about the Barber's phenomena. The point which I make is that if a person comes to a gastroenterologist, there are options which can be offered. There are surgical options which can also be offered because we have diseases and options in certain areas, definitely. And then the question is that how to choose. It shouldn't be a Barber's phenomena that if it comes to me, I operate. If it comes to you, do endoscopy. So, are these in these areas? Are these options competitive or should they be complementary? And therein I bring a point of interaction between the two specialities.
I fully agree with you. So, I mean, the other way of putting the same point is that if you have a hammer in your hand, everything looks like a nail. So it depends on who is holding the
Yeah,
hammer. Okay.
exactly.
So
Exactly.
now over a period of 35 to 40 years, you know that there are few areas where endoscopists have been able to do remarkably well, tackle a lot of load, and at least 90% of the problems can be tackled at their end. I mean, for example, endoscopic therapy of portal hypertension.
Yeah.
Okay. Um, so there, I think that the first aim should really be to let it be where expertise has developed, technology has developed. Therefore, you don't waste your time because if you remember the early studies on portal hypertension, that was also, by the way, by a surgeon. And he's the one who did devascularization surgery and shunts. So in a cirrhotic who's got child's B or C, that the results were pretty bad. I mean, you showed your
Yeah.
best results only in some child's A patients. So I think that there has been a lot of improvement in terms of the scope and expansion and its availability to many types of patients. So that part has established itself. Whenever something new comes, there is always a challenge because you have to prove that you're first equal to what is already existing. So at that point in time, I would say surgery, and thereafter to show that actually doing it by you, by endoscopic or other means, is actually better than surgery, which may or may not always be the case to prove.
Yeah.
And then the handicap also comes is because surgery has got a longer track record in terms of experience. So if you are talking about 15 years follow up, obviously the surgeons would have a longer follow up than, for example, the medical people.
So let's start one
Okay.
by one with that. So let me put first
Yeah,
one
yeah.
which is I think a remarkable improvement and addition to the treatment, which is for achalasia cardia. Now, so we used to keep on doing the Heller's cardiomyotomy, and that has evolved with laparoscopy and then robotic and biomedical precision, and then the poem which has come, which has made remarkable inroads in that. Now, the question is, where do we draw the line? The When do we say this is better, or how do we decide that which option to choose in a particular patient? Because gone are the days when post laparoscopy we would keep the patient for 7 days or 5 days or 3 days. Now they do go home the next day anyway. So, in your opinion, what do you think we should be offering what to which patients? Is there a role for
I
discussion?
Absolutely, absolutely. In fact, to be honest, I sent quite a few of my patients to my surgical colleagues here, Dr. Kriplani. You know, he was from AIMS. So if I have a very difficult patient of achalasia, maybe with a sigmoid achalasia, very thinned out esophagus, I think that, most of the non-surgical therapies have their problems because it's a very thin esophagus. Okay.
Right.
So just to put things in perspective for the audience,
Yeah.
so we had four therapies. One was, of course, the botulinum toxin. Now, the
Yes.
botulinum toxin doesn't work in that area. I do use botulinum toxin once in a while, but I'll tell you a very separate story on that. It's only
Okay.
sometimes when you want to know if this fellow is likely to
Benefit.
benefit from a different type of a procedure. So it's a trial almost, but it's risk free.
True.
Then came the long era when we were using balloon dilatation, high pressure
Yes.
balloon dilatation. If you remember, you were in SGPGI that time, and we did quite a few, and we published our long-term results with balloon dilatation, and it was
It's,
67% successful.
yeah.
Okay, so it wasn't 100%. Let's be very upfront about it. And from my personal experience, I can tell you that there were two patients who I thought I had done a perfect procedure, and post-procedure they somehow turned out to have a leak. Now, a perforated esophagus sometimes can be terrible. Okay.
Yes.
And both of them had to be operated upon. One of them I had to send to All India Institute, and he, of course, came out. Another one was in SGPJ. So now everybody knows that balloon dilatation, you can't do things under your close observation. It's under fluoroscopy, you're
Yeah.
dilating it. So complications of perforation are known. And if it occurs, it's bad, difficult.
Yeah.
But having said that, it has its advantages that you come in, you don't require an admission. It's almost like a OPD procedure. Keep the person till evening, give him some water under observation, and send him home. On the other hand, Heller's myotomy, laparoscopic Heller's, I think that overall the success rate has been very good. And as a surgeon, you have also understood why some people have better outcomes than others. So there was the long debates as to how long has to be
Long the
the
myotomy has
cut,
to be. Correct.
myotomy has to be done and all that. If you are young and the anxiety is that will there be very good relief of dysphagia, then the tendency is to make the myotomy long. You
Yeah.
remember those days we used to
Yeah. Yeah.
discuss how long it should
An
go now?
extension onto the stomach and things like that. How
Yeah,
much?
yeah, yeah.
Exactly.
Now, if you look at it, poem actually does more or less the same thing. That is,
Yes.
you're doing a myotomy, but not from the outside, but from the inside.
Correct.
And again, what has happened is that since poem is in its early days, there is an understandable anxiety that the operator would want that the outcome should be very good in terms of dysphagia control.
True.
Now, what has happened is that when you have retrospective data or analysis, then you find that if you overdo the part of myotomy, it is complicated by reflux.
Reflux. Yes.
So the official figures are 9 to 15%, but if you actually do a pH metry, you might find it goes up to 30%.
30,
Okay.
35%. Yes.
Now, poem is in still, I would say, an early phase of evolution. So, exactly how much to cut, whether it's the anterior fibers or the posterior fibers, how long should the myotomy be? I think that those are the same kind of things which the
Yeah.
surgeons did about 40
Dealing
years
with.
back,
Yeah.
which we are doing now. So I
Yeah.
don't think that there is an ideal situation, but if I have a difficult case, like I have a person with a sigmoid esophagus, very thinned out esophagus, long-standing disease, I still think that surgery is a safer option. In fact, one of my patients, I remember, the surgeon actually had to do a esophagectomy because
Yeah. We need
it
to.
was quite a bad one. Yeah.
Yeah.
So there, I think if a very adventurous endoscopist tries to do a balloon or tries to do a poem, it is fraught with danger. So I think there is a need for being able to
Yeah.
think
No,
openly and discuss what is best for him.
and clearly, type 3 achalasia with
Hmm.
this thing. Poem is definitely superior because you can make a long myotomy. But on the other hand, I feel we can do a good myotomy by surgery and anti-reflux procedure also. So, and the recovery period is more or less very quick in that. So that's why I feel that we probably need to offer the patients the pros and cons in a very open manner. Sometimes what happens is if it's non-surgical is very attractive to patients, and they don't realize that that is also minimal invasive as is surgery, because there is anesthesia, there is intervention, and then there is a recovery period, isn't it?
I would fully agree with you. In fact, I'll tell you, achalasia probably it is an area which is evolving rapidly. In fact, as soon as poem came, I was surprised that there were reports from all over the country where people said that they've done about 2000 poems, you
I
know.
know, I know,
I
I know.
was wondering how did this
Where
happen?
did these come from?
Where did this come from? So everybody was on that number chasing game, you know. And
Yeah.
I didn't see so many achalasia coming to me that I would
Exactly.
refer.
Yeah, yeah, yeah. I
Yeah, but
understand that.
but where surgery has actually done even better when it comes to the lower end of the esophagus. Sadiq, in those days when you and I used to work, a lot of patients had hiatus hernia and reflux.
Yes, yes.
And those days, we were primarily resorting to an open, uh, surgery
Fundoplication.
with the
Yeah,
fundoplication, Neeson's
yeah.
fundoplication. Nowadays, I think laparoscopic fundoplication has become so well established
Yes.
that from my side, my threshold for referral has come down a lot.
But it's interesting that you got this GERD in the discussion, the GERD. And I put to you that, there are so many now endoscopic anti-reflux procedures, and they've been there for a long time, like the TIF and Stretta and things like that. Why they have not been so, commonly employed in patients, as in contrast to poem, which is being offered to every patient. So what is the difference, and why there is this difference in endoscopic procedures for anti-reflux problems?
So, in the last, I think, about 25 years that I have been in gastroenterology practice, I think that endoscopic procedures for GERD, they have come and gone. There have been at least 5 or 8 of them. They
Yeah,
all come with a huge promise. There is a workshop and somebody who looks very flashy and confident does a procedure. But at the end of the day, it has to be easy to do, predictable, safe, because you're again doing it for a
consistent. Yeah.
consistent, and also you're doing it for a problem which is more inconvenient rather than life saving.
Yes.
See, unlike, say, for example, a cancer or something like that. Okay.
True. True.
So there now, I think that the yardstick of long-term assessment also has to be fairly strict, and most of them have come and failed and gone back. At the moment, I think that 2 or 3 of them are still in vogue. One of them endoscopically now they call as a anti-reflux mucosal ablation,
Yeah.
ARMA. I've seen it. It's easy to do. Um, to be honest, I have not been too impressed with the short-term results because ultimately you burn an area and
Yeah.
then you expect it to cicatrize and therefore narrow the gap. It's
Psychiatrize in a
again
manner you would want it to.
want it to be. So, although it's fashionable, everybody wants to say that, look, I am doing it.
Mm,
I'm not too impressed. So, there is always going to be a placebo effect after the procedure. Some people will say that, yeah, I'm feeling a little better, but for how long you don't know. The
mm.
straighter part of it, it has come in mainly for reflux, Barrett's also to some extent, and so on and so forth. To be honest, when I get a difficult patient like that, I don't like to experiment too much. So if I have a good, reliable surgeon, I usually have a talk with him And I think that a time-tested procedure which can now be delivered laparoscopically,
Yeah.
I tend to prefer that. So quite a few of them leave me, but that doesn't matter to me as long as I think that the long-term outcomes are
Yeah.
better.
Favorite.
Track record of new procedures coming in endoscopy and then getting shut down have been very high, both with reflux procedures and with bariatric procedures.
Yes.
So
Yes.
that we have to be cautious before we tell the patient, look, this is a good option for you.
So, I mean, continuing in the same vein, like, you have for reflux, I'm sure you know this better than I want to hear from you. The lifestyle changes, medications, then endoscopy and surgery. I mean, these are all the interventions or options. What is your take on long-term PPIs? Now we are seeing a lot of problems with PPIs. So, what is your take on long-term PPI? And how do you decide that when is the time that now these guys should go for surgery?
I think that the list of complications associated with long-term PPIs are going up. So it's about 40 years that the PPIs came into the market. So the
Yes,
list is growing.
yes,
So there are three types of complications. One is related to long-term acid suppression. One is related to the drug itself, causing certain things like hypomagnesemia, iron deficiency, and so on. And the third is that you really don't know whether long-term PPI would be very safe. Some of them have come in for a bit of question, like the kidney issues and the heart issues and all that. The problem, on the other hand, is that it's easy to take, it is cheap. In general, if you look at the uh, frequency of serious side effects, it is a bit low. And in fact, if I might tell a small story for the
yeah,
audience,
yeah.
so there is this lady, she was, I think, around 75 or 80. And incidentally, she came from Calcutta, the business family.
Hmm.
And every now and then at night, she would get a reflux and it would
Yeah,
cause panic. And her husband, who was around 80, would have to drive her to the hospital. And
yes.
then they would get a Pantocid or a Rantac injection. She would be okay and come back. It was so traumatic for them. They came and I said, look, the problem is of reflux. So either you continue with PPI or you get a surgery done.
Yeah,
She opted for surgery because she said that the panic and inconvenience is so much and we are getting older. I would much rather get it done. So then I told her that, look, your age is not exactly on the favorable side.
hmm.
But you know what she said? She said that I am willing to take the risk, and if I can get the surgery done, if I live for another 5 years, I want a better quality of life.
Yeah,
And she went through the surgery and she came back from Calcutta to tell me that she was doing much better and to thank me. So
yeah.
I think that sometimes you have to individualize and see how
True.
the patient wants it, but to a
Yeah,
large extent, one has to be very fair with giving both sides of the coin. And if
yeah.
it is a younger person, for example, say in his 40s, requiring high dose PPIs, I would have a lower threshold for sending for surgery. The reason is he has got 30 years ahead,
Yes,
and he is going to pop that pill all along. So he has to be a little more, shall we say, pushed to accept it. There's another difficulty also, and the difficulty is that you mentioned lifestyle.
yeah.
Lifestyle does work. The
Yeah.
problem is that it's very easy for the doctor to advise lifestyle and for the patient to nod and say yes, yes, but it doesn't get done.
Sustain
That's
it
the
for a
problem.
long period.
That's the problem. That's the
Yeah.
problem.
So, I mean, you brought this about the procedures and all, and I want to just dwell a bit on that. Generally, what I've seen, and it's not to any specific procedure, but in general, uh, we like a particular procedure has taken a period of time to for us to develop skills on that, know what are the issues, do it properly over a period of time, and now you've sort of so-called mastered the procedure, or you know how to do it. And then this new kid on the block comes and says, oh, but we are going to do this in this manner, endoscopic or whatever. Now, there is a learning curve. There is a period of establishing the uh, veracity of that procedure, the long term results of that. So, how do you counsel the patients? I mean, in real life scenarios, that one is established procedure, other is we don't know how it is work. Because what I feel generally is patients are taken in simply by the fact that it is a lesser invasive procedure, irrespective of what is the outcome and the credibility of it.
I would agree with you. So what happens now? Sadiq, you also trained as a surgeon. I also trained as an endoscopist. So initially, na, we were also in a way trying to develop our skills, and our psychomotor skills. So I guess that was a time when if there was any opportunity of a procedure, we would put the case in a way that would be a little more convincing for the patient to accept
Yes,
the procedure. And
yes,
that is how we all learned. I mean, in the sense, fair or unfair, but those were young days and we all learned. Now, what has happened is that, particularly in the West, I'm telling you, in the Western world today, the opportunity for trainees to get a hands on to do procedures is quite low. And that is the reason why they would actually go and grab the patient and the
opportunity.
procedure
Yeah,
opportunity. And unfortunately, many of them come to India now for doing hands-on in ERCP, where
yeah,
some people do it for a fee and all that. Ethically, I think it is wrong. The reason being that I think the procedure is probably risky. You have not yet been established or adequately trained. You're trying to kind of uh, pick up or hone your skills, psychomotor skills, and you have patients who are not likely to be very demanding, so that combination worries me a bit. And I have a feeling that one of the things that is evolving but not has evolved enough. When we were learning directly on the patients,
yes,
which I think was unfair. See,
unfair.
today, na, I think that for training, you have to have very good models of training. For example, today, if you look at airlines, and airlines is one of the safest
Yeah,
industries,
yeah.
they actually have to practice a lot on a module and then see
Simulation. Yeah,
simulators and then move forward,
yes,
which did not happen adequately with medical and surgical teams.
absolutely, absolutely. I think that's a very important point because now hands-on is becoming more and more difficult. And, you know, you brought the aviation industry, they have simulation for each airport and each condition. And uh, it may not be that difficult to have for each clinical condition and even a complication with that. So I agree with you that that needs to be done. But I'm glad that because it's the same with surgery, that there are people who are embarking on new procedures without having established its credibility, and just because it is new, people are sometimes gullible and they accept that. So I think we need to be careful about that. That's an important point. One more thing I want to talk about in GERD GC is Barrett's esophagus. Now, this always confuses me and it worries me also. Two things about it. One, Barrett's, is it an absolute indication for surgery? And B, does it reverse or revert post surgery? What is your experience?
So when we talk about Barrett's, there are two parts to it. One is, these are these tongue-like projections of the gastric mucosa into the esophagus, which
Yeah,
is associated with long-term reflux. Those Barrett's are not necessarily always precancerous or dangerous. And that is where the problem comes. So as soon as a person gives a label of a Barrett's, it almost sounds like a death nail, that you might as well desperately get something done.
Hmm.
So now I think the studies have adequately shown that only if it shows persistent high-grade dysplasia,
Yes.
then it is an indication because the chances are high that it will move on to cancer. Hmm. So excess panic is a problem. So a lot of my patients come because they have had an endoscopy in a remote place. They have been told Barrett's and they have it. Incidentally, let me put the other side of the coin also into the picture. So lower esophageal cancer is one of the cancers which has been on the rise in recent decades.
Yes.
But when we say on the rise and you look at percentages, if it was say 3 out of 10,000 and it becomes 6 out of 10,000, it doesn't mean it is going to be World War III.
Yeah.
Okay, so,
Or a
so you have to
very
put things in
incremental increase. Yes.
perspective. So it could
Statistically
be,
increase. Yes.
yeah, it could be doubling, but the chances are still quite low. So I think that we have to be more factual and tell it to the patients also. If the suppression of inflammation is good, that is good amount of PPIs if the person is not symptomatic, most of the dysplasia part regresses. This has been well shown. If it is a dysplasia which is more than 50 to 70% not regressing, that is a matter of worry.
Hmm.
Because usually what happens is the inflammation due to acid reflux, if it comes down with acid suppressant,
Yeah.
generally they do well here. I mean, I have a whole lot of
Yeah.
75-year-old who are
Yeah.
continuing and they are likely to die of a heart attack or Alzheimer's, but not due
Yeah.
to esophageal cancer. Okay.
Yeah.
So
Yeah.
the thing is, you have to put it in perspective. The other thing is that for some unknown reason, Barrett's, the typical Barrett's, which is a precancerous Barrett's,
Yeah.
is a little less common in India than what it is reported in the West.
Hmm.
So if that we saw, and I usually look at the patient in a very individualistic manner. So
Yes.
if this fellow has got a coronary artery disease, he has got diabetes, he's has got an endoscopic Barrett's but no significant dysplasia,
Please. Yeah.
and he is doing reasonably well, and he probably has 5 years more to go, going by life expectancy statistics. I wouldn't push him to get a major procedure done. But
Hmm.
if it is a youngish fellow, 45, 50, with a
Hmm.
pretty bad Barrett's, with some degree of dysplasia, unlikely to change his habits. And if he is willing to go in for some kind of a surgery for Barrett's,
Hmm.
so many of them actually do reasonably well even with a fundoplication because once the
Yeah.
reflux part comes down, now
Yeah.
you don't actually have to cut the Barrett's part. The
Yeah.
Barrett's part needs to be cut only if there is
I
significant
agree.
dysplasia.
Yeah. I
I,
agree.
so I think they do pretty well.
So you brought about how to counsel and talk about these patients. So you've written a book recently on uh, human touch in modern medicine, right? Bringing patient care back into healthcare. That's the title.
Yes.
So, GC, very interesting. What prompted you to write this book? Do you think you felt and you've experienced or seen that there is a tremendous decline in compassion, empathy in the interaction between patients and doctors?
So there has been a decline. I mean, whether it's a huge decline or not, I won't like to comment on that. But there has been a decline because let me put it this way. Uh, when you joined AIMS, to do your MBBS, I think the motivating factor was probably not money.
Yes,
You liked the job. I mean, there was a certain amount of, call it altruistic feeling or a glamour associated with being a doctor.
yes,
Today, if you look at people joining medicine and why it is so much in demand, it's because they look upon it as a lucrative profession. And if you go by the simple logic that, there are seats which are going on sale for 1 crore
yes.
per seat, see,
Mm.
obviously, whosoever is going to pay that money, his parents or his family is going to expect the returns quickly.
Sometimes I feel if I have so much money, why be a doctor?
Quite right. But you see how we can sometimes be unfair, I'll tell you.
Yeah,
If you inject the idea that, oh, this is a Barrett's, but if you Google Barrett's, you will find it's a precancerous condition. Obviously the fellow is going to take
yeah,
whatever advice you give to tackle the Barrett's, although the actual chances are going to be very low. So this
yeah,
is what is called as a subtle fear mongering, which
yeah,
also many of us
yeah.
tend to do to
Do
suit our convenience. Yeah.
yeah. Going back to this book, so I'm very enamored by this concept. There is a tremendous decline in the how we interact and the compassion and empathy in that. But how do you think we can bring that back in the system?
You know, uh, this empathy and understanding of human relations primarily occurred in the earlier generations. I mean, I would put you also in that category, although you're not a vintage. It is basically by reading storybooks. You
Mm.
see, books now usually tell stories about
Yes.
individuals' lives, and that is what brings in empathy. Today, na, there is very little of reading in the sense most of
Mm.
it is social media. So,
Yeah.
social media would be creating an impression, giving you information, but it doesn't always convey the emotion in a let's say, longitudinal manner.
Yeah.
So today, one of the methods which is used everywhere that you
Mm.
must read
Mm.
storybooks because it is through stories that you understand human emotions. Second thing is role modeling. So if you have a role model who does it that way,
Yes.
the chances are that the student would also think about it if he has to
Yes.
deviate.
Yeah. Well
These
said.
are two things.
Yeah.
And to be honest, today na, our yardstick of success has also come down. If you
Changed.
see a fellow who's got two swanky cars and he's going to Europe for holidays, a very successful surgeon or a physician, many people would actually like to emulate that model rather than
Yes.
actually say that, look, I'll do less but be happy with less. It
Yeah.
doesn't work. It sounds
Yeah.
altruistic, but it
Yeah.
doesn't work.
Yeah. Absolutely. Well said, GC. And I think it's something which we all need to be worried about if it's declining this aspect. Let's come back to the signs a little bit more. Another one which I feel has a constant tussle is the inflammatory bowel disease. Now, from the surgeon's perspective, we don't want to operate Crohn's. That's for right. And the second part is we don't want ulcerative colitis to go on for very long on medical treatment, come for surgery, having sort of become proficient at doing a pouch and so on and so forth. Now, in this era of the anti TNFs and all, do you think there is a change because we have these in our hands and we can prolong the patients to go for surgery? And is that beneficial or is that approach the appropriate approach?
So my best teachers are patients. So I'll tell you about this lady, very, very intelligent lady, very well to do. She had ulcerative colitis, which was picked up in Bangalore because she had iridocyclitis.
Hmm,
And the ophthalmologist said, get your gut checked up. She had a little loosies. And this was, I think, almost 15 years back.
hmm,
And then she has been on steroids, she has been on 5 amino salicylates, then she has been on biologics,
hmm,
adalimumab, and all that.
hmm.
And when she came to me because she got transferred from, she was in some fancy school, mistress, uh,
Okay.
director. So she was in Gurgaon, and then we tried all the things, Remicade and this and that. She developed Clostridium difficile infection that got treated, blah blah blah. To
Hmm,
cut a long story short,
hmm.
there has been a huge evolution in the medical therapy for ulcerative colitis and Crohn's, and I think it has been a good thing. The reason I'll tell you,
Hmm.
in our time, na, it was primarily corticosteroids, and today, na, corticosteroids is something which we really hate to give
Yeah,
because it does produce
absolutely.
long-term side
Yeah.
effects. Okay, so now you have got tofacitinib, upadacitinib, biologicals, and so on and so forth. Even Azoran I don't give much. The results are pretty good. And interestingly, IBD occurs in young people at the very productive phase of life. And as soon as you diagnose ulcerative colitis, the next question they ask is, so, sir, is it an incurable disease? Now, how do you answer that? Uh, it is a manageable disease, to be
Yeah.
honest. But
Yeah.
is it curable? The answer is probably no. It will keep coming back and they're not
Yeah.
happy. So what's the alternative? The alternative is to do a surgery and get the colon out if colon is the source of the problem. But again, this concept of a ileostomy and a three-stage procedure is something which doesn't appeal to a lot of people. I mean, let me be very
Yeah.
upfront.
Yeah.
Now, this was a patient in whom we tried everything, and she was in one of my clinical trials where I was using itrasimod. It was a global trial. For
Mm.
2 years, she did well, and then after that, itrasimod stopped working, and again, she tried everything, including Stellara and all that. Very
Mm.
frustrated. So when I get into these situations, I usually take a second opinion. He also went through, scratched his head, and said that, look, I can't see anything more. If this doesn't respond, then a colectomy is a good answer. I said it's good. So she's
Mm.
probably thinking, but is going in for it.
Mm.
These type of cases, I think that, maybe we should pick up more often, a bit earlier, and hopefully things would be good. On the other hand, I would say that the number of patients that we used to see of severe IBD have actually come down because of early institution of many of these therapies, which are pretty good. The second part of it is that Crohn's. Once diagnosed to be Crohn's, we were very worried that look, if you cut and resect, it will come back.
Yes.
And sure enough, I see a lot of recurrence, but I'll tell you which are the patients who come with recurrence. These are patients who have had a resection after getting some control, and then they were made to believe that the problem is over for good,
Over. Yeah.
and they were not on any maintenance therapy.
Mm.
So
Mm.
the disease record
Mm.
restructured. So some of them have got 3 surgeries done.
Mm.
You have to put
Yeah.
the patient on a therapy so that it doesn't recur. Crohn's, I'll tell you that with my surgical colleague, we have done, I think, about 40 patients. The results are pretty good. The only
Yes.
thing that he tells me and I tell him is that get the disease in good remission
Yes.
with biologics or whatever it is.
Mm.
And then you do a clean resection anastomosis. Even
Mm.
primary anastomosis holds.
Yeah.
And therefore, I have found that the outcomes are pretty good. Ulcerative colitis, the pouches have actually come down, but they are still occurring. And maybe that debate which we had earlier on, that are we delaying too much, that debate was a little more relevant when we were pumping too much steroids. But
Yeah.
now, if the patient can afford the other medicines and they're tolerating it, it's not such a bad deal.
Say, for example, patients are on biologics and all, and then they come for surgery, and then we have a good meta-analysis which says that, complications, all these are much more in these patients. And then when they come for surgery, perhaps the results are not as good as we would like it to be. And then it is ascribed to, oh, that's why surgery should not be done and all. So my point is, and I come back to the first question, that is there a time now for multidisciplinary management of benign disease? We know it is important in cancer care, but in benign diseases would help the patient to get the right option at the right time.
I would agree with you. One thing which I think is a little dangerous, Sadiq, is to quote international data.
Yes, I
I'll tell
agree.
you why. Because those are done by the best of people under the best of circumstances. For example, emergency ERCP in patients with
Yeah,
suspected
biliary
biliary
pancreatitis.
pancreatitis.
Yeah, yeah,
And 130 patients, there were no complications. Okay.
yeah,
Now,
yeah,
if you use that data to support the fact that doing emergency ERCP in biliary pancreatitis is safe,
yeah,
it's a disastrous
yeah,
interpretation.
yes.
So we also have to assess our own individual expertise, team expertise, and what works best.
Yeah,
But I agree
I
with you
get
in
what you
principle.
are trying to say, and I agree with you completely that we can't just extrapolate the Western data to our patients because they behave differently. Also, sometimes the diseases spectrum is also very different, and we see this most of the time. But I feel that in this specialty, there is a lot of scope of working together. I think being together and having confidence in each other's ability would help us sort of sift out the right option for each individual patient.
I
Yes,
couldn't agree more with you, Sadiq. They were good old days when we used to dream. If you have a team of a
yes,
good endoscopist, a good surgeon, a good radiologist, and a good interventionist,
yes,
okay,
absolutely.
you can almost tackle anything here.
Yeah.
The fact is that you have to know each other, trust each other, and be compatible.
So, GC, it was good fun talking to you on these things, but any parting words? Why I ask
No,
is, how do you motivate yourself? I mean, you've had such a long career, you've had forays in various things, in preventive medicine, in writing, in endoscopy, in academics. So, what motivates you?
so I do my reading. I still, because of my background career, I am called to give talks or attend conferences, which I think is good because much of the learning also occurs when you listen to people sitting in the audience as to what is going on, which way the winds are blowing.
Yeah.
So this book that I wrote, I put my heart to it. I actually describe the situations where I think we need to be different. And whether things will change or not, I have my doubts because there is sometimes it's a wave, it goes in a direction. You can't actually stem the tide.
This is how you get inspired. And I think your book would probably bring back at least a realization that what we are missing.
This is the one which you are referring to.
Yeah.
Okay.
Yes. Yeah.
So the
Yeah.
human touch
In
in
modern medicine.
modern medicine, putting care back at the center of healthcare.
Fantastic. It's a great talking to you, GC. I'm glad we got you on this podcast. And thank you very much for sparing your Sunday morning.
Pleasure, Sadiq.
Thank you.